Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Good evening, everybody. This is Dr. Ravin Garg. I'm a hematologist oncologist at Maryland Oncology Hematology, and this is another podcast for Oncology Radio. I'm happy to introduce Dr. Santa-Maria, who's an assistant professor at Johns Hopkins in breast cancer, and I'm grateful to have him as part of this interview today. Hey, Cesar, good morning.
Good morning, Ravin. Thank you so much for having me on. Delighted to be here.
Thank you for coming. And so, Cesar, I was hoping if you could just tell the audience a little bit about your background, where you grew up, what your clinical interests are, how you came about to go into oncology in particular.
Sure, yeah, no, thank you. I'm a Canadian native, and my family moved to the US in the early 2000s. I did my undergraduate at the University of Dallas, my medical school at UT Houston, and then residency at UT Southwestern before doing my medical oncology fellowship at Johns Hopkins. After fellowship, I had my first faculty position at Northwestern in Chicago. I was there for 3 years, and after that, I had the opportunity to come back to Hopkins, and that's where I'm currently at, where I'm an assistant professor here in oncology. My clinical focus is in breast cancer. I treat patients of all different types of breast cancer, all different stages of breast cancer. But in addition to my clinical my research hat, I'm interested in immunotherapy and how to develop new immunotherapy-based treatments, how to understand a little more about the disease. I work closely with several laboratories here at Johns Hopkins and elsewhere to develop clinical trials evaluating immunotherapies for breast cancer.
Cesar, that's fantastic. So I was hoping to ask you some questions regarding neoadjuvant treatments for breast cancer. And so for the audience, when we talk about neoadjuvant treatments, these mean that we offer systemic therapies as medical oncologists prior to a patient undergoing surgery. So Cesar, in your macroscopic view, what are the advantages of neoadjuvant treatment in general for breast cancer?
Yeah, absolutely. So, neoadjuvant treatments for breast cancer have actually been around for quite a long time. Historically, at least, the reasons we would think about doing preoperative therapies would be for operative indications, meaning, in a patient who may have had an unresectable tumor, if you give some treatments before surgery, you can potentially shrink it down and make the surgery now feasible. In patients who want to have less surgery, whether it might be to convert someone who's a candidate only for full breast removal, like a mastectomy, to partial breast removal, like a lumpectomy or partial mastectomy, that would be another reason to think about neoadjuvant treatments. If you have lots of lymph node disease under your arm at diagnosis, sometimes if you get a good response, you can do less axillary surgery, and that's something that can help with overall outcomes as well. But in addition to those, practical surgical indications, the neoadjuvant setting is really helpful for a couple of reasons. One, it helps us with risk stratification, meaning, we can identify patients who may be at higher risk. So for example, in patients with triple negative breast cancer, if after we do neoadjuvant chemotherapy, they still have residual disease, we know those patients may be at a higher risk of recurrence. And in fact, there's actually treatments that we can offer, so post-operative treatments for patients with residual disease that can help offset some of that increased risk. So for example, in triple negative, it's not uncommon to recommend capecitabine, an oral chemotherapy in this setting. But there are actually clinical trials in this space post-neoadjuvant treatments. And likewise, there's similar examples for other types of breast cancer, like HER2-positive breast cancer. Those with residual disease may be eligible for a treatment called TDM1, trastuzumab and tansine, which can again offset some of that increased risk. But beyond identifying, individual patients who might be at increased risk, the neoadjuvant setting is also a helpful model for drug development and biomarker development. So we can start developing new treatments using this model because we know we can measure complete response rates after neoadjuvant treatments. So for example, if you add a certain treatment in the neoadjuvant setting to standard treatments, if you see that that treatment increases the rates of complete response, that may mean that that could translate to potential benefit. And in fact, in breast cancer, we do have an example in patients with HER2-positive breast cancers where the drug pertuzumab was used in this setting where data in the neoadjuvant setting showing that it increased the path CR led to an early drug approval.
And Cesar, one thing I read an article from New England Journal of Medicine, Keynote 522, and in that study, I believe it was for triple negative breast cancer patients, but they integrated pembrolizumab, one of the immune therapy drugs that's getting a lot of great press for a variety of different malignancies, and that it improved the pathological complete response rate. And for the audience, pembrolizumab essentially takes off the brake on the T-cell lymphocytes called PD-1. It unleashes the immune system to help you fight the cancer. It kind of reinvigorates your immune system, and it's really been a game changer for a variety of malignancies. So, Cesar, I was hoping if you could discuss, what your thoughts were about, Keynote 522. What about triple negative breast cancers in particular that may suggest a higher response to immune therapies in general? And do you think it's ready for prime time? Would you use it in your clinic for a patient with, let's say, a stage 3 triple negative breast cancer?
Great questions, Ravin. And definitely, I'm keenly aware of the 522 study. This was a really important study. This was a very large study, a phase 3 study that randomized patients with early stage triple negative breast cancer to chemotherapy with or without the immunotherapy agent pembrolizumab. And in their analysis, they found that the complete pathological response rates were about 65%, which is really high compared to what we typically see in this patient population. But there's a few caveats, and the devil's certainly in the details. The chemotherapy backbone used in Keynote 522 was not what I would consider a standard chemotherapy backbone for a few reasons. One, dose-dense AC, doxorubicin with cyclophosphamide, a very standard chemotherapy treatment for patients with triple negative breast cancer in particular, was not used. It was given every 3 weeks instead of every 2 weeks. And that actually matters because that has implications in long-term outcomes. So that's one issue. Another issue is that they used a chemotherapy drug that's not standard called carboplatin. Now, carboplatin has been found to improve complete pathologic response rates. But besides just improving response rates, the bottom line for patients is, can you cure my cancer? And carboplatin has not yet been demonstrated to improve recurrence rates. So, and unfortunately, adding it to a chemotherapy backbone does increase toxicity substantially. So, it's a fine balance of when we use that agent. And then finally, in that particular study, I just mentioned about how capecitabine is used for patients who don't achieve a path CR. That study did not incorporate that agent. And that agent, the capecitabine, has been studied in a few randomized studies and consistently shows to improve survival outcomes. So there's some issues with the chemotherapy backbone, I think, that we need to consider as we move forward. And then the other thing too, well, we had a 65% path CR rate. The toxicity rate was really quite high, what we call grade 3 and above, so high grade toxicity. So pretty serious side effects was 80% in that study, which, for a group of patients with potentially curable diseases is quite high. In the clinical trial, unfortunately, there were treatment-related deaths to this combination. So, right now, again, we do see that it improves path CR rate, I would say modest to moderately, but we don't have yet very mature recurrence data, so event-free survival. So I think we're certainly waiting on that. So for that reason, I don't think it's quite yet ready for prime time. We don't really know that for sure this will lead to improved recurrence rates, particularly when you factor in the increase in toxicity. And I think we'll always be left with a question, well, how does it compare to a more standard chemotherapy backbone?
And Cesar, I think your point's very well taken. Now, is there something about triple negative? I remember many years back, Dr. Nanda from University of Chicago published an article in Journal of Clinical Oncology where it showed that pembrolizumab seemed to be more effective in the triple negative cohort, more so than, let's say, estrogen receptor positive or HER2 positive. Is there anything about triple negative that you think might portend a better chance of being susceptible to immune therapy, Cesar? Is there something biologically about that subtype of breast cancer?
Yeah, absolutely. Thanks for that, Ravin. I think as breast oncologists, we're very used to categorizing breast cancer by the standard receptor subtypes, right? The hormone receptors, ER/PR, the HER2 receptors. And really, when we think about implementing immunotherapy, those receptors may provide some general guidance in terms of subtypes we think might be more responsive to immunotherapy, but I think there's a lot of other biological features of tumors that may help predict responses. So some of the things that are very clearly demonstrated to be predictive for immunotherapy are things like tumor mutational burden, where patients who have lots of mutations or are hypermutated do tend to respond well to even just a single agent, immunotherapy agent. Likewise, patients who have microsatellite instability, a DNA repair malfunction that can result in lots of mutations, and it is also a biomarker that can help identify patients responding to immunotherapy. Triple negative breast cancers may be a little more hypermutated than other tumors, but there are other markers that we're really interested in looking at. So, a lot of these immunotherapy agents target the PD-1, PD-L1 axis, which, as you mentioned, are kind of like the brakes of the immune system. So kind of, inhibiting those brakes to activate the immune system. PD-L1 expression is more common in triple negative, or their microenvironment, kind of where the tumor nests itself, compared to other subtypes of breast cancer. They do tend to have more immune cells infiltrated as well. So a measure we look at sometimes is tumor infiltrating lymphocytes, or TILs. Indeed, in the metastatic setting, PD-L1 is a biomarker we use to help identify patients with triple-negative breast cancer who may benefit from immunotherapy. But there's lots that we're still trying to learn, and I'll selfishly segue a little bit into some of the things we're looking at Johns Hopkins. Kind of along the story of the tumor mutation burden. Resulting in better response rates to immunotherapy. We're trying to look at new biomarkers, and one in particular we're interested in are spliceosome mutations, specifically SF3B1. And this is a mutation in spliceosomes, which are the cellular machinery that process RNA. So, typically DNA will be transcribed to RNA and then translated to proteins. And proteins are ultimately what immune cells may potentially see. So by having abnormal spliceosome machinery, this results in abnormal protein production in cells. So an increased or a diversified neoantigen landscape, which is kind of the rationale behind hypermutated tumors and MSI. Increase the sensitivity to immunotherapy. So we're conducting a clinical trial right now for patients with metastatic breast cancer of any subtype who have this specific spliceosome mutation called SF3B1. And what's really cool about this study is that it's a virtual clinical trial. It's completely remote, meaning patients just visit our website, they put in their information, they upload their genetic report, which is a very common thing for patients to have nowadays. Many commercial laboratories do genetic testing on tumors. And if they have that mutation, they have metastatic breast cancer, our study team will contact them and will present their case at our molecular tumor board, which is a panel of specialists in genetics, cancer genetics, clinical oncologists, pathologists. We review their case, and then the output is a report with recommendations. And that report is given to the patient and the patient's local oncologist, who then decide, if immunotherapy is recommended, does this make sense in my clinical circumstance? And the local oncologist would basically prescribe what would amount to an off-label immunotherapy, but with a report, hopefully aiding and being able to get that drug off-label, as it provides rationale for treatment. And then what we'll do on the back end is we'll just follow these patients with questionnaires every few months. The patient never has to come to Baltimore, where we're located here at Hopkins. This can be done anywhere in the mainland US. And again, what we're trying to see is get a sense if patients with this mutation may benefit from immunotherapy.
Cesar, that's amazing. I don't think I've ever heard of a clinical trial being essentially virtual in essence. That's amazing. Is this a new concept for you at Johns Hopkins?
This is the first kind of treatment virtual trial that I'm certainly aware of. I will say this is the brainchild of Dr. Ben Park, who was at Hopkins, is currently at Vanderbilt, whose laboratory provided a lot of the scientific rationale for spliceosome mutations in immunotherapy. As far as we're aware, this is a novel concept. It's called the PRISMM study, PRISMM, and you can check it out at clinicaltrials.gov. If you put PRISMM and probably my last name, Santa-Maria, you can find it. And again, it's available to anyone in the mainland US. And it's a feasibility study to see if a virtual trial is feasible. But of course, we're interested in response endpoints.
So I think that's remarkable. And for the audience, we're trying to, as oncologists, find biomarkers for tumors to better tailor our treatments, because if we're going to offer treatments that may have some toxicity, we certainly want to make sure it's effective. So I think that's really great. These are really digging down deep in the tumor phenotype to predict responses for therapy. Cesar, so I'm going to switch gears a little bit. I would like to talk about estrogen receptor positive and HER2 negative breast cancer. And one thing that always struck me, Cesar, when I talk to patients, everyone in oncology talks about after 5 years of treatment being completed, we talk about patients are cured. And oftentimes we're grateful to say that they are. I have noticed and I have read, for estrogen receptor positive breast cancer patients, sometimes after 5 years, we see a dreaded late recurrence, year 10, year 15. I think Olivia Newton-John, the very talented actress, that happened to her. And I was hoping if you could discuss, number one, just about estrogen receptor positive. What is it about that cohort where sometimes we see late relapses? And then the second part of the conversation I was hoping to get your opinion on, please, is what are your thoughts for younger patients shutting down their ovaries and giving an aromatase inhibitor versus 10 years of tamoxifen? And then lastly, I would like to talk about the Monarch E study, I believe, with abemaciclib. That was, I believe, at ESMO. It was presented at ESMO several months ago. So I was hoping if you could kind of walk us through your opinion of all of estrogen receptor positive breast cancer.
Yeah, no, absolutely. So, I mean, of course, estrogen receptor positive breast cancer is the most common subtype of breast cancer, for a disease that affects, about 250,000 women a year. It's a major health issue that we deal with. So, different subtypes of breast cancer, I guess just, the way I like to explain to patients, when we make a diagnosis, there's two important components. The stage, is this early stage, is this metastatic, and the subtype of the breast cancer according to the receptors, right? So the traditional receptors are hormone receptors, estrogen and progesterone receptors, and the HER2 receptors. And depending on what's positive, what's negative, we assign a clinical subtype. So for those with hormone receptor positive or estrogen receptor positive breast cancer, the recurrence rates are different compared to some of the other subtypes, like triple negative or HER2 positive breast cancer, which follow the more traditional 5 years, and then the risk really drops off. Up to 50% of recurrences in ER-positive breast cancer will actually occur after year 5. So, it is a substantial number of patients that can still experience recurrences even after year 5. The risk is not as high necessarily as in other subtypes of breast cancer, but it is a cumulative risk that, unfortunately, it doesn't really ever go away, and there's a couple of reasons for that. There's what we think about as more traditional, like a recurrence of a primary cancer, so a cancer that you had before that returns in either in the same area or a different area in your body, and that may be due to some of the ways the cancer is able to hide itself, go into a state of dormancy, and there's lots of theories and hypotheses as to how that happens. I don't think we very clearly understand. Certainly immune evasion is probably part of it. But then the other thing too is that, having a diagnosis of breast cancer does increase your risk of having another diagnosis of breast cancer. So especially for women who are initially diagnosed with a hormone receptor positive and inborn breast, they could be diagnosed with another breast cancer in another breast. So kind of the approach we have to address kind of both those issues. So what we call a primary prevention issue in preventing a new breast cancer, but also decreasing a secondary prevention approach and decreasing the risk of a recurrence. A large part of it is the type of anti-hormone treatments we use. And, historically the go-to drug was tamoxifen, a SERM, a selective estrogen receptor modulator, an oral pill that's taken for 5 years. And then the other major class is the aromatase inhibitors, which lower estrogen levels and are really strictly only for women who are postmenopausal. So there's been two ways of optimizing the endocrine part of treatment in patients. So for one is the duration of treatment. So there's studies that have looked at 5 versus 10 years of tamoxifen, and in the two most recent larger studies looking at that, the Atlas and Adams study, it did seem that a 10-year course of tamoxifen compared to a 5-year course did improve recurrence rates significantly. And then for patients who are premenopausal at diagnosis, adding ovarian suppression, so these monthly shots that decrease ovarian function can also decrease recurrence rates. But it's not one recipe fits all for everyone. It has to do a lot with your baseline risk. So the kind of patients we're thinking about doing extended endocrine therapies for, or we're thinking about adding ovarian suppression for, are those patients who have some high risk features, typically larger tumors that involve lymph nodes. There's some additional tests we'll sometimes do in the tumors, like an oncotype or a mammoprint, looking at the grade. There's several pathological features that we'll kind of put together. And we do know that women who have low risk cancers, 5 years of endocrine therapy is very appropriate. Folks can do very well with that. But again, in patients who have higher risk disease, doing these kind of longer treatments, potentially adding ovarian suppression if you're premenopausal can be helpful in optimizing outcomes. Kind of optimizing endocrine therapy is one part of it. And then you were asking about the Monarch E study. So, these interventions are purely, the ones I just talked about are endocrine based, but we're learning about some of the resistant mechanisms in hormone receptor positive breast cancer. And one of the success stories, at least in the metastatic setting in patients with advanced breast cancer, has been the addition of CDK4/6 inhibitors. These are basically inhibitors of the cell cycle, just kind of the way a cell progresses and is able to divide. It kind of freezes that process and it causes cell death. So there are several CDK4/6 inhibitors that have been approved in the metastatic setting. But in the early stage setting, there's only one that's shown to have some benefit in a phase 3 study, and that's what was investigated in the Monarch E study, where the CDK4/6 inhibitor abemaciclib was added to endocrine therapy in patients with higher risk hormone receptor positive breast cancer. So particularly patients that had like lots of lymph nodes or had some higher risk features in their pathology. And they did find that indeed it did decrease recurrence rates. And while it's not yet approved, this is a very large study that does impact, that will impact clinical practice, and I think is a helpful tool in patients who have very high risk disease. And I think just broadly speaking, I would say it's that same balance as I mentioned with the immunotherapy. It's about balancing, achieving your goals of the best possible clinical outcome in terms of decreasing recurrence rate with toxicity. Because as you make treatments longer, as you pile on the endocrine therapy, as you add in the CDK4/6 inhibitor, the cost is toxicity. So again, identifying who the right patient for this is really key. And that's something that, oncologists need to talk carefully with their patients about.
So I think it's a wonderful point. The thing I was struck with the Monarch E is with the cyclin 4/6 inhibitors in the metastatic space where they are approved, palbociclib, ribociclib, abemaciclib, they seem to be pretty much interchangeable parts to a large degree, when you give them in conjunction with anti-hormonal therapy. But I heard about the PALLAS study with, I think, palbociclib, where it was actually a negative study. This was in the adjuvant space. So it just seemed really interesting to me that abemaciclib shows a potential high promise in the adjuvant space. But as of right now, palbociclib did not. Any thoughts about that? Different drugs, even though it's the same class of drug, or any theories on how that perhaps happened?
Yeah, no, I think that's a great point. As you mentioned, clearly in the metastatic setting, at least in terms of progression-free survival, they all the CDK4/6 inhibitors do seem to be somewhat on par. overall survival in the metastatic setting, so kind of more of a top line endpoint, has only been demonstrated with ribociclib and with abemaciclib. It's not been demonstrated yet with palbociclib to my knowledge. So, could there be something there? Maybe. We don't know yet for sure. So the PALOS study compared to the monarchy study, I think besides different drugs, the main obvious difference is that they were different patient populations. They did include lower risk patients in PALOS. And, I think something we commonly see in oncology is, to be able to show an effect size, you need a sufficiently high risk population. And that's good, right? Because we don't want to treat necessarily patients who are lower risk with all this additional therapy. So, we'll be eager to see further analysis from both PALOS and monarchy in terms of getting a better understanding of the patients who may benefit from these therapies, and if there's any biomarkers, that can help with patient selection. But right now, where the data is that currently for early stage breast cancer, I agree that PALOS is a negative study. There's no role right now for palbociclib, but I think if you're going to think of a CDK4/6 inhibitor in the early stage setting, really the only option right now based on currently available data is abemaciclib.
Cesar, thank you. And a few more questions if I could, but I wanted to shift our focus into the metastatic space. So as you had mentioned earlier, unfortunately, some of our patients present as stage 4 disease, or they have stage 1, 2, or 3, and they progress to stage 4 over time. So one study that struck my attention was the IMpassion 130 with atezolizumab. So I was hoping if you could talk about the results of that study and what it's meant for your patients.
Yeah, absolutely. So the IMpassion 130 study was a study in patients with metastatic triple-negative breast cancer in the front line, meaning when they initially had a recurrence event. And it evaluated adding the chemotherapy drug albumin-bound paclitaxel with or without the PD-L1 inhibitor atezolizumab. The way the study was designed, it wanted to look at progression-free survival and overall survival. There's one important caveat in that study design. For overall survival to be demonstrated in the and they looked at both the whole population and patients with specifically who had the PD-L1 biomarker. For the overall survival to be considered statistically valuable in the PD-L1 positive population, it first had to be demonstrated so in the whole population, in the intent to treat population. So what that study found was that there was a modest improvement in progression-free survival, about 2 months or so, a little bit longer, 2.5 months in the PD-L1 positive population. But the overall survival, and now we actually have pretty mature overall survival data. The final overall survival analysis was presented at ESMO last year. I did not find a benefit in the intent to treat population. Nevertheless, an exploratory analysis of overall survival was done in the PD-L1 positive subgroup, and numerically, it was certainly exciting. There was, it's about a 7 to 9 month improvement in overall survival in the PD-L1 positive population. However, this is not what we would consider a statistically evaluable finding. So I think that's a little bit the challenge where we run into right now in terms of thinking about atezolizumab and metastatic triple-negative breast cancer. The FDA did provide an early approval, what's called an accelerated approval, based on the PFS data. But now, I don't know what's going to happen as we have this more mature overall survival data. I do think it is important to prove statistically significant benefit to be able to say something's going to be clinically helpful. So I think that's the challenge with that study. Kind of a similar study in that space, was the Keynote 355 was kind of like the Pembro equivalent study of that. So again, first-line metastatic triple-negative breast cancer, and it looked at pembrolizumab in combination with other with other chemotherapy agents. It looked at nab-paclitaxel, regular paclitaxel, and gemcitabine with carboplatin. And there they had a kind of a different study design. First, they required showing benefit in patients with high levels of PD-L1 expression before they looked at lower levels or the entire population. And what they did find was that PFS was most improved in patients with high PD-L1 status, what's called a CPS greater than 10. And the improvement in PFS was about 4 months. So, a little higher than what we saw in the Impassion study. But the study has not yet reported overall survival data, so we don't know if this still a relatively small improvement in PFS is going to really result in improved overall survival. And so based on these data, the FDA did grant pembrolizumab an accelerated approval in metastatic triple-negative breast cancer. So, I think it's still early days for adding an immune checkpoint inhibitor in metastatic triple-negative breast cancer. They are options right now, certainly. Both atezolizumab and pembrolizumab have accelerated approvals, but, clearly we need to do better. I'm hopeful with more novel combinations, looking at new immune-based combinations or in patient selection, seeing if there's a subset of patients who seem to be responding better, we're going to be able to make some more meaningful headway there.
Cesar, that's wonderful. So hypothetically, if you had, let's say, a 65-year-old, these are for triple-negative patients, so stage 4 triple-negative disease, and the PD-L1 had to be greater than or equal to 1%, and Impassion 130, as you mentioned, 10 CPS for the Keynote 355 study. Is there a regimen if you had a patient who had de novo stage 4 metastatic triple negative disease, PD-L1, let's say, was 15 or 20, CPS was 15 or 20, is there a regimen you would choose right now, or is it really hard to say if you had to pick between one of the two regimens?
Yeah, so that's a great question, and I do want to make an important point. So, so the Impassion 130 study looked at a specific antibody called SP142, the Ventana assay, and it required that PD-L1 expression was 1% or greater. It's a different antibody and a different cutoff for the Pembro study, right? It's the 22C3 antibody, and it required the CPS to be 10 or greater. There is a lot of overlap in, a 1% SP142 and a 10% cutoff 22C3, but it is not a complete overlap, and they are identifying to some degree separate patient populations. What we're trying to do here at Hopkins is, when we have a patient like this, we'll test for both. Just to see if one is positive and one is not, and we could choose treatment according to whatever is positive. If both are positive, I think either is fine. We don't know if atezo or pembro is better. But there could be circumstances where one PD-L1 marker is positive and another one might be negative. So it could potentially expand your treatment. I will say, in general, I do think these regimens offer modest benefit. What we're trying to do at Hopkins is, build a clinical trial portfolio that's looking kind of at the next generation of combination immunotherapy agents. And, we're working on opening several studies looking at new combinations with newer immunotherapy agents. We're hopefully going to be opening a study in the next few months looking at a personalized vaccine in combination with immunotherapy, and kind of see if we can, continue to push that bar a little further. But right now, in terms of what's available as a standard of care, both atezo and pembro both have accelerated approval, so they are, options for patients right now.
So I think it's a fantastic point. Ideally, it'd be nice to have a uniform testing for all these treatments so it's uniform so we can predict. So that's a great point. The assays might have a little bit of heterogeneity, involved. And Cesar, one last topic I would like to talk about, if I could, is metastatic HER2 positive breast cancer. And I know that there was great data from Dr. Swain with Cleopatra looking at taxane, trastuzumab, and pertuzumab. Then we talked about TDM1 in the Catherine study earlier. We have that approved in the second line space for breast cancer. And I read with interest this drug, trastuzumab deruxtecan, and also another drug, tucatinib. And I was hoping if you could talk about what the data for these that got these drugs approved by the FDA and what it means for your patients with metastatic HER2 positive breast cancer.
Yeah, no, absolutely. So certainly our armamentarium for HER2 positive breast cancer is increasing with really exciting next generation treatments. So how you mentioned, I think a very classical frontline treat for patients with metastatic HER2 positive breast cancer would be this THP regimen, adding pertuzumab to a taxane and trastuzumab. And a very standard second line approach would be using TDM1. But beyond that, it hadn't been very clear, what do you go to next? There's a few what we call tyrosine kinase inhibitors, so small molecules. These are oral medications that target HER2. There's lapatinib, neratinib, and now most recently tucatinib. Lapatinib and neratinib have been compared head to head, and neratinib has been found to be a little more effective than lapatinib, but tucatinib has not been compared to the other two. However, tucatinib is the first TKI to clearly demonstrate an overall survival benefit, and kind of how we talked about overall survival is, it's kind of our high-end endpoint in terms of when we think about treatments for patients, what we hope to improve. So tucatinib was studied in the HER2CLIMB study in combination with trastuzumab and capecitabine versus just trastuzumab and capecitabine. And this was done in patients who had, mostly patients who had received previous pertuzumab and TDM1 as well. So it really sets it up as an option for a later line treatment. One interesting finding in that study is that, since HER2 positive breast cancer unfortunately has this predilection to metastasize to the brain, and a lot of drugs really can't get in there. A lot of the HER2 TKIs, so these oral agents, are small molecules, and they can actually penetrate the brain. And tucatinib was found to have significant clinical benefit in patients with brain metastasis. So I think it makes it a particularly attractive option for patients with brain mets in the later line. Trastuzumab deruxtecan TDX is also it's an antibody drug conjugate. So similar to TDM1, it's got a monoclonal antibody targeting HER2, and there's different chemotherapy modalities that are stuck onto it. And this again was studied in a very heavily pretreated population, and response rates were actually very dramatic. It had, I believe, a disease control rate of like 97%, which
wow,
pretty impressive. So a very active agent, certainly. It is a bigger, bulkier agent, so we don't know how it will do in patients with brain metastasis, but it may benefit those patients as well. So definitely for patients, who have a lot of systemic disease in the later lines, that's a drug that I would certainly consider, just because it's a very active drug, and patients can stay on it for quite some time.
And so I was going to say, with the tucatinib, to be able to get brain penetration and maybe obviate the need for radiation to the brain is a potential win for some patients. So that's a very exciting point you brought up. So Dr. Santa-Maria, I wanted to thank you for coming to this podcast and for being such a wonderful colleague for our entire group. We refer a lot of patients to you, and we have a wonderful collaboration with you in Johns Hopkins. So thank you for your time and for your clinical and research efforts.
Absolutely. It was my pleasure, Ravin. Great to talk to you here, and very much enjoy working with you and your group.
And good night to the audience. We hope that you'll tune in again to Oncology Radio.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.